Hi, I'm Danielle Dick, and I'm the director of the Rutgers Addiction Research Center. And I'm delighted to be here today with Dr. Lewis Nelson, who is a professor in the chair of emergency medicine up at the New Jersey Medical School and at University Hospital. So, Lewis has been an amazing partner with the RARC, someone that I've really enjoyed getting to know over the past year. So, thank you so much for joining us this morning.
Oh, thank you so much for having me.
So I wondered if you could start by telling researchers out there a little bit more about your department and the kind of work that you're doing.
Sure. We are a mid-sized academic department that is very focused on clinical care. We run the emergency department clinically here at University Hospital in Newark. And most of the faculty are interested in clinical care writ large. We have a subset of faculty who are expert in medical toxicology, about 6 or 7 faculty, and our interests largely in that world, and I'm one of those faculty members, has been on the overdose and withdrawal side of the addiction spectrum, and less perhaps focused on the long-term care. We do a lot of work in the transition from acute and emerging care into long-term treatment. And so we put a lot of our resources into that sort of effort, both harm reduction and overdose prevention, as well as transitions of care, particularly in the opioid space, but we also work in other areas too. We also have a big focus on the poison prevention because the poison center is medically overseen by my department here for the state of New Jersey. So we've done a lot of work looking at childhood exposures, particularly lately with cannabis and with opioids.
Yeah, obviously the changing cannabis landscape is likely to be a fruitful area for research
Sadly.
exploration and staying on
Mhm.
top of. So I know that you are involved in a variety of addiction research programs, both in terms of supporting faculty in your department, and I believe that you're also involved in the Center of Excellence, along with Dr. Petros Lavonis, the chair of psychiatry, who we've also spoken to as part of this series. And so I wondered if you could talk a little bit more about your involvement with the center and some of the research that is specifically going on with the faculty in your department.
Sure. Yeah, the center largely is run out of an area called the Care Center, which is it's just a long-term addiction treatment center that's in one of the buildings that's right next to the one that I'm currently sitting in Newark. We have had some grant funding independent of the care of the Center of Excellence / Care Center that's allowed us to work to transition patients from the emergency department into the care provided at the care center, mostly funded through SAMHSA. It involves things like peer navigator programming and things like that to allow us to hire both peers and professional navigators who've been able to work with our patients to engage them to be interested in long-term treatment, and then of course to follow up with that long-term care. Through the Center of Excellence, we also help to sponsor a training program, a fellowship in addiction medicine, which my department and 4 of my faculty, well, 2 particularly involved, but 4 of them are involved in the education and training of the addiction medicine fellows, who themselves come from a variety of backgrounds, including emergency medicine, which is something that excites me to be able to take our own graduates and put them into an addiction medicine training program.
So one of the things that we know is that there aren't enough addiction medicine specialists out there, clearly, to address the scope of the problem. And many researchers come from a variety of different backgrounds, but many of us, myself included, are PhDs rather than MDs. So can you talk a little bit more about what does an addiction medicine fellowship look like, and how does that compare to the training that you might get in dealing with addictions, just kind of in a regular medical school training?
Yeah, it's a great question because there's no specialty in medicine that addiction doesn't touch. So it's hard to say that we don't all know something about addiction, but there's a difference between working with patients with addiction, practicing our specialty, whether it's cardiology or orthopedics or even psychiatry, to managing them as a primary patient. and really understanding the ins and outs, the psychology and the medical issues associated with substance use of a broad array of substances. That's what makes addiction medicine so special, because it's not using, understanding addiction principles and practicing by primary specialty, but it's actually incorporating every specialty's patient population into ours. So most physicians can manage patients with substance use. This is not something that's particularly complicated. The systems around it are important. Breaking through the stigma associated with managing, the fear associated with managing patients with substance use is challenging, which is why we get so involved. So in the Addiction Medicine Fellowship, it's a multi-part fellowship, but a big part of what we do, for example, is inpatient consultation at University Hospital. You would be surprised, I guess, in how unfamiliar many clinicians are and how uncomfortable many clinicians are with the management of patients with substance use, the fear of managing them, both alcohol and the risk of alcohol withdrawal and opioids, and really not understanding how to use methadone, how to use buprenorphine, how to assess for withdrawal and understand the needs in the pain medicine aspects of care, that it really involves specialty level care to be for us to actually engage with these clinicians and with this patient population. So a big part of addiction medicine training is really understanding how other clinicians interact with the patients, in addition to taking the patients on ourselves and trying to manage them. But so I'm most involved with the hospitalized patient population, but the addiction medicine fellows go out and work in long-term treatment facilities. They work in outpatient treatment programs like methadone clinics and places like that. So it's a multi-partite training program, of which we're involved in a very discrete aspect of it. But a big part, again, of what we do is that very early phase. So, spending some time in the emergency department, working with naloxone distribution and understanding the role of naloxone in harm reduction, understanding buprenorphine initiation, which again occurs in acute care settings as well as clinic settings, but in the hospitalized setting, and understanding the different strategies that are needed, particularly now that we're seeing a primarily fentanyl-based, opioid use, but alcohol withdrawal, benzodiazepine dependence and withdrawal, these are all really important in the management of the patients that we see in our training program and in our clinical population.
So you do a lot of work at University Hospital, which you talked about. And can you talk a little bit about the patient population that you're working with there?
Well, we really do, support the patients in the community of Newark and the surrounding towns. It is, as many people know, it's a fairly urban, somewhat disenfranchised and marginalized population. There's a high degree of substance use disorder, and a lot of it is opioid, but we see a fair amount of alcohol and we see cannabis. And, cannabis, particularly, we see a high population of people with cannabinoid hyperemesis syndrome, which is a little bit unique. Much of the cannabis that you see in other communities is related to the long-term use disorder and maybe some of the psychiatric components of it, which we do see here. But we have a lot of people here who have extensive use of cannabis in common with hyperemesis, just as an example. So our population is, largely that I've already mentioned, with very poor connectivity to healthcare. They're underinsured or uninsured. So accessing care, which seems, even with Medicaid, to be difficult to be able to do. And we're able to get our patients onto Medicaid when needed. We have systems in place to help to support that. But they don't have often the family structure and the educational base to really understand the important role that long-term care has. Often they are, as I said earlier, stigmatized by their community and the healthcare system. So in order to get them to really engage has been fairly challenging. Now, every population has its challenges. I'm not trying to suggest that a different population it's super easy. It's a tough disease. It's a disease that you probably would not wish on your worst enemy, honestly, because it leaves detritus in its wake as it goes. Family and friends and coworkers are all affected by it, and it's long term. It's never really cured. It sounds very dark, but it's what we deal with. It's the population that we used to managing.
So you talked earlier about something that's emerged in other conversations with different clinical providers across Rutgers, which is really how so many doctors feel ill-equipped to address addiction, or they'll feel like this isn't in my wheelhouse, and really our ability to treat, to understand the causes, and to have medications for a variety of substance use disorders has advanced a lot over the last decade plus. And I'm wondering what your thoughts are on why that continues to persist, and how we do better moving forward.
That is the holy grail question to answer. I really don't have a great answer. I have my own opinions about it. I think there is a certain feeling that it's a hard population to work with. They're not good at following up. They tend to not be very compliant with their treatment regimens. As you can imagine, they are often, burdened with other behavioral health disorders as a component or a confounder of their substance use. I think that so there's a population-based component. I think there's a messaging component that we have in our educational programming that buprenorphine in particular is hard to use because of the risks of precipitated withdrawal. Remember, we used to have a waiver that was required in order to be able to prescribe. We made it seem like it was this very complicated drug that you needed a PhD to be able to prescribe. But the fact is that if you understand the principles of how to use the drug, it's pretty easy to use. It's safer than methadone. It's certainly safer than using substances on the street. And if you look at the risk benefit of either of those medications compared to the use of street drug and the risk of adulterants or infections and other things that are required by the use of uncontrolled, poorly quality controlled substances you buy illicitly, it is a far better option to be learning how to use, learning how to use buprenorphine or methadone than it is to avoiding those discussions with your patients. Now, what we do to make it easy is we just provide an easy referral source for them. I would much prefer, particularly buprenorphine, which any prescriber can order, can prescribe. Methadone does require, when it's being used for opioid use disorder, it does require connection to an outpatient treatment program. You can't just prescribe that for patients. And so there is a certain amount of complexity built around the methadone use system. But even the inability to understand when to think about referring your patient to a methadone maintenance program or getting the addiction medicine service involved has been a bit of a challenge. So I think there's a certain fear that we've imparted into clinicians that has made a problem. And I can't avoid discussing the fact that, we just don't reimburse it very well. Doctors are humans. We want our patients to pay for their care. And Medicaid doesn't reimburse well. Not everybody has Medicaid. It's often a process to get the patients, connected up to Medicaid and get their enrollment information, get their health insurance put in to our systems, bill, collect, and do that. So it's hard to ignore that. It's just not a lucrative part of medical practice. And not that everything has to be lucrative, but people want to get paid for the work that they do. So I'm not sure that's the driving factor. I think the other two are probably more important, but it's hard to ignore that as going to be a factor.
Yes, and I think this really speaks to the many levels that are involved in thinking about how best do we treat substance use disorders, all the way, like you said, from the systems that are in place to include policy, insurance, stigma, et cetera. When we were having a conversation with Dr. Petros Lavonis, who I know you work closely with, and who, of course, is the president of the American Psychiatric Association this year, he was saying that he feels like we've done ourselves a disservice by constantly emphasizing the complexity of substance use disorders, that in fact, many of the things that we address and treat in medicine regularly are very complex. There's genes, there's their environment, you have to manage multiple components of it. And so he was saying saying that he's trying to emphasize that actually all clinicians can do something and, don't need to be afraid to kind of step into this arena, because if you ultimately go back to what's important, at the highest level in terms of helping improve people's lives, this really is an area where, everyone in medicine can make a difference. And
No doubt. And even if they don't want to do it on their own, they should be able to identify it and refer the patients to proper care.
Well, I'm grateful that we have individuals at Rutgers like yourself and so many others who are really leading the way in terms of how do we do this well on the clinical services side, and how do we start to work through and navigate these logistics. As a researcher, it makes me think about there's a lot of amazing opportunities for implementation research here, and thinking about how do we create best practices in our hospital system that will really improve patient care. I'm wondering if you can also speak to other areas where you might be interested in partnering with researchers, or research, areas that you would like to see grow in terms of connections or collaborations with your department.
Absolutely. I mean, I think there's a lot of work yet to be done on the epidemiology aspects of substance use. I'm very involved, again, as a medical toxicologist. I'm very interested in the substances per se that people use. So we've done a lot of work with what we've kind of familiarly called fentanylogs, which are, fentanyl analogs, which, as most people recognize, the heroin supply pretty much contains no heroin anymore. It contains fentanyl, but there's many different fentanyl analogs or derivatives that are in the supply, which have different pharmacological properties than fentanyl itself. And we've been looking a lot at a lot of the epidemiology and clinical effects of fentanyl and fentanyl analogs, not to mention the adulterants like the one we have been talking extensively about lately, which is xylazine. But there have been many other adulterants and even contaminants that have made their way into the drug supply. So a big part of what we do is looking at the clinical consequences of the presence of the different opioids in the supply and the other things that are in the drugs, including looking at co-use of drugs like amphetamines and opioids, or benzodiazepines and opioids. I'm also very interested in alcohol. I mean, I've done a lot of work in alcohol withdrawal in particular. I think better understanding the harms and the mechanisms to reduce alcohol consumption and the risks associated with consuming alcohol. And of course, as I mentioned before, my area of interest being alcohol withdrawal and optimally managing alcohol withdrawal. I've done some research in the past and worked with other groups to try to support them in understanding best practices. There's been a lot of discussion lately about changing the approach in alcohol withdrawal from a benzodiazepine-based approach to a barbiturate-based approach. And so we're trying to look at some of those issues as well. If we go back, I mentioned earlier, to some of the cannabis issues, we'd love to partner on better understanding the harm. Now, as a medical toxicologist and addiction specialist, I tend to be a dark side doctor, right? I know there's a lot of people out there that think cannabis is basically soma, it's the fruit of the gods. It's been handed down to us to cure all of our ills. I tend to see more harm, both medical harm, but also sociological harm and sort of existential harm that comes from the widespread availability of cannabis. And I am not a supporter of its wide use. And you can argue about recreational use or adult use as being a personal choice. I think the medical use of it is a bit misguided, because there's really no scientific support for any of the purported medical uses of it. So I think by branding it as something that we, given our imprimatur on as a medical group, that it's safe and effective is problematic. So I've spent a fair amount of my efforts, and I'd like to continue to look at proving the benefits if they exist, but certainly making sure we understand the harms and the risks that are associated with its broader implementation. Certainly the one that's most apparent to us through the poison center in our department here, we have a busy pediatric emergency department, is edibles. And we know we just see dozens of children who come in after what is an apparently innocuous exposure to a gummy or a brownie or something like that, the parents or friends leave around, that the child gets into. And while fortunately death is not a typical outcome, it's still a pretty problematic exposure. and harrowing for the parents. And obviously it's not intentional, but these are the kinds of things that we really have to better understand. So those are areas I'm very interested in looking at. Not to mention, still, I spend a lot of my time, like Petrus does with the API, I work a lot in the emergency medicine world, trying to really make sure that emergency physicians understand how to identify and initiate treatment for people with opioid use disorder primarily, but we've been looking at alcohol use disorder too, the initiation of naltrexone and acamprosate in the emergency department for alcohol use, and the initiation of buprenorphine, and even starting people on methadone in the emergency department for opioid use.
Well, thank you so much for all that you're doing in this space. It's really been, an honor for me to get to partner with such great and enthusiastic clinical providers who really are kind of leading the way in how do we do better. And I would be remiss if I didn't mention the fact that we are trying to work together to recruit another research faculty member who could be embedded in your department and really create bridges between the Rutgers Addiction Research Center researchers and the kind of innovative work that you're doing there up in Newark. Do you want to say a little bit more about what you are ideally looking for in this position?
Well, we would love to hire somebody who could really take the bull by the horns. I mean, we have a couple of researchers in the department. I mean, I'm mid to end career, and I really want somebody to pick up and, run sort of interference and help grow the research program in the department. We have both a strong clinical population here and throughout the system. If they're interested in clinical work, if it's more of an epi focus, we have a lot of connections to various other resources in public health, medical examiner, poison center, big data through Rutgers and RARC and other groups. So we're really looking for somebody who's able to both provide mentorship to the junior faculty and develop their own research portfolio or expand. I mean, I presume they would have one already, but expand with the depth of the Rutgers resources that we have available to the RARC and through NJMS and Rutgers writ large. I mean, we have a lot of opportunity here for somebody to grow a very formidable research component or research strategy within emergency medicine and acute care addiction management. So I would love to be able to find somebody who could take on that sort of role, and they could, if they're interested in being more involved in the med school side and having a vice chair position or being, anything that we could do that would help to improve the collaboration between, Rutgers Addiction Research Center and my department and NJMS would be open to discussion and something I'd be happy to talk about.
Well, if anyone out there is looking to join us on all this exciting work at Rutgers, then please reach out to either Lewis Nelson or myself. And Lewis, thank you so much for spending some time this morning talking about all the work that's going on in your department.
Hey, it's been my pleasure, honestly, and thank you so much for having an interest in inviting me to speak with you.